Welcome to our webinar. My name is Wendy Profit. I'm a field marketing specialist with Axonics Therapies. I'm pleased to be moderating this program and appreciate you joining us. This evening, Dr. Kaeser will be speaking about bladder and bowel dysfunction, the common symptoms patients experience, and treatment options that may help you gain control. Without further ado, I'd like to introduce Dr. Kaeser. Dr. Kaeser, thanks for sharing your time and expertise with us this evening.
Hi there. Good evening and welcome to our webinar, and thank you for joining us. My name is Dr. Carson Kaeser, and we're going to talk tonight about controlling bladder and bowel. So a little bit about me real quick. I went to Ross Medical School. I trained at the University of Tennessee for residency, and then did my fellowship training in urogynecology at the Christ Hospital in Cincinnati and the University of Cincinnati in Cincinnati, Ohio. And I'm currently practicing at Erlanger Hospital at the main campus, which is downtown, and at Erlanger East, which is out kind of by the mall on Gun Barrel Road. So we want to talk about bladder and bowel, like we said. And so if you look at these little cartoons here, like this person saying, I drink less before I go on a trip, or I miss the best part of the show because I had to use the restroom, or I always have to have a bathroom nearby because I worry I'm not going to make it. Well, that's kind of the people that we are targeting this for, and we're going to talk about what we can do to help. Other things to always remember is that you are definitely not alone. This is a really large problem. We're going to talk about that in just a second. So if you can look at this right here, this is saying that overactive bladder is probably somewhere close to 50 million people in the United States. And actually, this data is pretty old. This comes from 2004, 2009, and some other ones that are a little bit sooner or later, I mean. So it's probably more like 65 million. And then if you look down at the next line where it says an additional 20 million people suffer from fecal incontinence or accidental bowel leakage. So these are major problems, and nobody really talks about this, but that's why we're here tonight to talk about this. And also, half of these people, of these numbers, of the 65 million people with overactive bladder and the 20 million people with accidental bowel leakage, only half of these people are actually seeking treatment. So if that says anything about this, is really common. So let's understand what we're talking about and the conditions that we're going to discuss tonight. So the three main things that we're going to talk about, one is called overactive bladder. And overactive bladder is that sudden urge to go to the bathroom, like, gotta go, can't hold it, run into the bathroom, and, maybe having an accident if you can't make it. The other thing we're going to talk about is urinary retention. So in the middle here, people who have difficulty urinating or can't empty their bladder well, that's something that we're going to talk about. And then, of course, fecal incontinence, also called accidental bowel leakage, and that's the involuntary loss of stool. So there's one other condition we're going to talk about in a minute too, but that's not really the scope of our talk, but I do want to mention it because it is important. So how does the bladder normally work? Well, the bladder fills up during the day. Obviously, as you drink more liquids and fluid, it gets more full. And then nerve signals are sent to your brain to let you know that it's full and it's time to urinate. And then once it's time to urinate, your bladder contracts, but your pelvic floor muscle also relaxes, kind of allowing the urethra to open and urine can come out. So that's normal function. So back to overactive bladder. So like I said, this is a gotta go, can't make it to the bathroom. This is sometimes just urgency and frequency, but a lot of times it's also having accidents because you can't make it. So urinary frequency just means I gotta go all the time, usually 8 or more times a day, but really, if it's just more than you're comfortable with. The next thing is urinary urgency. And this is where I can make it 2 or 3 hours and I'm fine. But if it hits, I really have to go. And sometimes I can't hold it. And then there's urge incontinence, which is where you just can't hold it. And then nocturia. Nocturia just means you're getting up more than one time at night. If you get up one time at night to go to the bathroom, that actually is considered like okay and normal. But if you get up more than one time at night, that's not normal. So what happens with overactive bladder? Well, how does it happen? So these are like abnormal communications between the bladder and the brain. It's really a nerve problem is what it is. So this leads to feeling an urgent need to go to the bathroom. And sometimes your bladder squeezes so hard, you can't stop it and it comes out. So this is just the gotta go, can't make it. So I mentioned there was one other type of incontinence tonight we're going to talk about. So stress incontinence it's not because you're stressed out. It's because you're putting abdominal pressure on your urethra that makes you leak urine when you do things like coughing, laughing, sneezing, jumping, bending over to pick something heavy up. And this is a completely different problem. That's actually a problem with the urethra. So the tube that you urinate through should be closed like the whole time, but for some reason, if you cough, laugh, or sneeze, it opens and then urine comes out. So that's not what we're really going to talk about, but I definitely want to make sure people understand the difference. That is another problem completely, and that's going to be saved for another talk. But back to the overactive bladder, if you have the urge to go and can't hold it, but you also have an urge, but if you also cough, laugh, sneeze, and urine comes out, then that's called mixed incontinence. And a really large portion of my patients have both of these. And a lot of you probably do too. So leaking when you cough, laugh, and sneeze, but also leaking if you can't hold it. Okay. So how does the bowel normally work? Well, it's pretty similar to the bladder. So as the rectum and the rest of the bowels kind of fill with stool, there are little receptors that kind of stretch, and it tells the stool and it tells your brain that there's stool in the rectum and needs to come out. So these nerve signals go up to your brain. Your brain says, okay, it's time to have a bowel movement. You sit on the toilet, your pelvic floor muscles relax, and then the bowels can push the stool out. So that's how it normally works. And we believe that fecal incontinence or accidental bowel leakage is the same kind of thing as overactive bladder. It's a nerve problem. So obviously fecal incontinence is if you lose stool, either solid stool, liquid stool, or anything that when you don't want it to. So there's fecal urgency. Like a lot of people have this too, where they don't have accidents, but they just cannot, like they have to go so bad immediately, but it could be hours between needing to go. And then there's urgency with incontinence, which is where you feel the urge to go and then you can't stop it. And then there's passive incontinence also. Passive incontinence is where you think everything's fine, and then you find out in your underwear that you've accidentally, passed some stool into the underwear. So that's passive incontinence. So, all of these can impact someone's life, like physically. So like you limit participation in sports or going out to dinner. Social things too, like you don't want to go over to friends' houses, you may cancel trips. People feel guilty about it. They have a loss of self-confidence. Even sexual problems, like people don't engage in sexual intercourse because they're worried they may have an accident. This can affect work. I mean, people may miss work or have to leave work often to go. And then obviously wearing pads and diapers. I mean, it's a major problem and affects a lot more, I think, than what people think. But people also say that it's something that they did, or this is just a normal part of me being a woman. And as I get older, this is just something that's going to happen. But that is absolutely not true. This is not normal. It is very common, but it is not normal. Okay, so it's not something you did. But there is good news. So we have treatments for it. So we're gonna talk about this. So here are your options. So for overactive bladder, the first thing that we would do would be, of course, you need to go speak with a physician. You discuss your symptoms, and usually what I like to do is get like a baseline diary, like a bladder diary, talking about when you go to the restroom, how often, how many accidents you're having. And then sometimes we do an exam, we may do some tests, and then we're going to discuss treatment. So easy things to do would be like cutting back on fluids, like 64 ounces or less, going to the bathroom more frequently, like on an alarm clock. People who get up a lot at night, I tell them don't drink anything 4 hours before they go to bed, and then adjust it as needed. Pelvic floor physical therapy is also a really important kind of cornerstone treatment of what we do. A lot of women get a lot better with just going to see a pelvic floor physical therapist. And this is not doing Kegels at home. Like, this is actually going to see a pelvic floor physical therapist. And if these things aren't making things better, then we can start the medicine. So I mentioned that this is a nerve problem. So we can try some medicines, and maybe the nerves can be blocked by these medicines, causing your symptoms to get better. And then if, after this, you're going to follow up again. And if you're still not better, like this little thing right here down here says, don't give up. Well, I think that's true. There are advanced therapies beyond the easy things, beyond the medicines. And we're going to talk about that. With urinary retention, so these are people who aren't emptying well. It's very similar. You're going to talk to your doctor, start a baseline kind of diary about what's going on. So maybe how often you're having to go to the bathroom and can't. And then sometimes if we have people catheterize themselves, how much they can go before they catheterize and how much they're catheterizing for. And then again, same thing. We can do pelvic floor physical therapy. There are some medicines that we can try. And then again, therapies down at the bottom. And we'll talk about these too. And then the same with fecal incontinence. I mean, it really all starts off just going to see your physician, telling them what's bothering you, and then kind of getting a baseline diary of kind of where you're starting from, and then going from there with all the different types of treatments. So initial treatment for overactive bladder. So we kind of talked about this. So going to see a pelvic floor physical therapist, or even doing this on your own at home, can do like bladder training. So training like by starting a timer on your phone for every hour, going every hour for a week just during the day, and then maybe increasing your alarm clock to go off by an hour and 15 minutes and going every hour and 15 minutes, and then an hour and a half the next week, and then an hour and 45 the next week, and seeing if you can kind of train your bladder and brain to get back on track with each other. Obviously, going to see a pelvic floor physical therapist does have about a 50% chance that it's going to make things better just by doing exercises with them. And then the next thing would be starting a medication. So there's several different medicines. There's probably 14 of them. And there's beta-3 agonists. So maybe you guys have seen commercials about a medicine called Myrbetriq or a medicine called Genteza. There are some older medications that you all may have heard of, like oxybutynin, detrol, ditropan. There's a whole host of them. And these all are medicines that try to help the bladder relax. So if these treatments are not working for you, then we can kind of go to the advanced treatment. So this one right here is called percutaneous tibial nerve stimulation, or PTNS. So if you see on this little diagram here, there's a person sitting in a chair. They've got their foot propped up on this little stool. And what we do is we put a needle that's like an acupuncture needle. It doesn't, some patients don't even feel it go in, but we go right kind of on the inside of the ankle. And then that needle is connected to a little battery generator that sends a signal up the tibial nerve into the same nerve root that the nerve to the bladder goes out of. And this involves something we can do in the office. It's usually 30-minute sessions that we do 12 weeks in a row. And if you're really happy with what it's done after the 12 weeks, then you would come in once a month for a 30-minute maintenance dose. So this works really well, but it is very time consuming. As you can see, I mean, you got to come in a lot, and you have to see me every single month, even after that, for 30 minutes. But it does work well. So this is an option for some patients who aren't good surgical candidates or just aren't quite ready to, kind of have surgery or procedures yet. This is something we definitely can do. The next thing that we do for overactive bladder is Botox. So Botox is used in almost every field of medicine nowadays. I mean, dentists who do people who grind their teeth, I mean, can put Botox into the muscles right here in their like in their jaw, and they don't grind their teeth anymore because Botox is a muscle relaxant. Well, the bladder is just a big muscle. And because the bladder is squeezing like this, injecting some Botox into the bladder can help it relax. So we do this in the office. I mean, we do it in the OR sometimes because people want to do this while they're asleep. But most of the time, people come into the office. We numb the bladder up with just some jelly that has like lidocaine in it. And then about 15 minutes later, we put a camera into the bladder through the urethra, and we inject Botox, and the patients can drive themselves home. This works really well also, and it can last anywhere from 6 to 8 months. So Botox is temporary, so it will wear off, like I said, so you have to have it done every 6 to 8 months, but it's easy, it's fast, and it works really well. So the next option is something called sacral neuromodulation. So this is a device, it's basically a wire that you can see kind of the diagram here. It goes into a small little hole on the tailbone, which is where the nerve to the bladder comes out of the spinal cord. So we're not near the spinal cord, it's just near the nerve to the bladder. And this wire goes into that small little hole next to the nerve in the operating room. And then we tape the wire down and hook it to a little battery pack that can power it. And you get to go home for a week and temporarily just try out this device to see if it's fixing your problem and making things a lot better. And if it does, and you're really happy with it, then you would go back to the operating room the next week with us. And then we would install, and you can see this little picture, there's a little battery that hooks up to the wire. And everything at the second time into the operating room is buried and completely invisible. And it can last anywhere from 15 to potentially up to 20 years. There's a couple of different companies that make these, but this works really well also. So we're going to talk a little bit about sacral neuromodulation, because this not only works for the bladder like we just talked about. So if you can do Botox, or you can do the little ankle stimulator, or you can do this little wire procedure. This also works for bowel as well. So we're going to talk about that. So what really is sacral neuromodulation? Well, we don't really exactly know how it works, which is really interesting because it's been around for about 27 years, and over 500,000, probably somewhere under 750,000 people have had this device placed now. But what it does is it's sending the signal from the bladder to the brain that somehow is disrupted and the bladder continues to contract all the time. It basically kind of makes that nerve start acting properly again. And not only does this work for the bladder, like we said, but it also works for the bowel. So people who are having accidents with bowels, this works the same way. And especially for my patients that have both overactive bladder and fecal incontinence, this is a great opportunity to try to get things better. So we kind of talked about how if you can imagine like those old timey TVs where you can kind of tune the knob on the TV and you can see static, and as you kind of tune it, all of a sudden the clear picture comes in, almost like a radio, kind of the same way. Well, we think the nerve between the bladder and the brain, that's what's happening, and that's why the signals are not happening the right way, and people are having accidents with their bladder or with their bowel. And so what this device is doing is kind of like the same thing. It's kind of making the signal just right so that things are working properly again. So it kind of restores normal communication, so hopefully improving your symptoms. So if we decide that this is right for you, obviously after you've tried all the easy things, fluid modifications, maybe some pelvic floor physical therapy, you've tried medicines and that's not working, well, then the next thing to do is to do this little trial. So like we said, you put a small little wire into the back, into your kind of right off to the side of the tailbone, and then you get to go home for a week, and no one kind of knows you have it because it's kind of covered up. And then this little lead is there for the week, connected to an external battery pack, which you can see kind of in the picture. So it's this little guy right here, and this is what plugs in, and this is what powers the device just for that temporary week while it's taped down to your back. And then you have a little remote control that can turn it up and down, and this is almost like the size of a key fob, as you can see. And you get to try it out for a week and just see what happens. And then there are two different batteries also. So there's one that's rechargeable, and that's this one. And you can see this is right next to a quarter, so you can see actually how small this is. It's very, very small. The other one that is not rechargeable, that can last for 15 years, is just a little bit bigger. So a lot of patients that I have other conditions like multiple sclerosis and Parkinson's, or they need a lot of frequent MRIs or other imaging modalities like a CT scan. So these devices are all completely safe for a full body MRI. So actually just about 4 years ago, you couldn't have an MRI if you had one of these devices, and we had to go take it out. You'd have the MRI and go put it back in. But now you can have up to 3T, which is a very strong magnet MRI, full body scan with this device, and don't have to take it out. All you have to do is just turn it off, which is really easy with your controller. So this is a little control, like the remote control that you get. So this remote control, you don't have to do anything. So say you choose this is working well during your test week, and we decide to put the battery in, and you're really happy with it. So this is a little key fob that you get. All you have to do is just keep this on you. You do not have to turn this on or off to go to the bathroom or to not have an accident or anything. It just stays on you. All you have to do is turn it on, and the device comes on, but your battery should already be on. But you can turn the volume up, which is turning the power up. Like say you're having a little bit more urgency or frequency than you've had over the past couple of months, you can just simply turn it up. And then you can also change programs, which are just different combinations of the little lead that we have next to the nerve. So it's very easy and discreet. I did mention that there are two different batteries. So there's one that's chargeable, or like a rechargeable. It's kind of like the rechargeable iPhones, where you can kind of, or any smartphone, you put on the little dock and it just charges like without any wires. This works the same way. You can see this patient has this little belt, and it kind of sits on the back right over. This is kind of where the battery would go, and it just charges, and you only have to do it. The older devices you would charge once a week, and then some newer ones are once a month. And now the new one that just came out, you potentially only have to charge this once a year, which is pretty amazing. So you can have this battery in for up to 20 years without ever having to mess with it, other than just charging it one time a year. So, and people ask, well, how easy is this charging? So all these patients that have had these devices, so they went and polled everybody, and they said after 2 years of therapy, so you can see here, 94% of people said that charging frequency and duration is acceptable. And this is really before that charging once a year device came out. So it's probably going to be even higher now. And then you can see 98% of people also were very pleased and saying they did fine with their charging. So, and then here's just a patient. This is Donna. She was 71 or is 71, sorry. And she was just saying how easy it is to sit, and she can read her book and she can charge things, and she has her keychain that's always on her keys and it's easy to see. So I think this is kind of an important slide. So this look back at people that have had this device just for the past 2 years. And you can see that 93% of people. So this means that of all these people that did this little test week where they went home with their device and they were happy with it for the week, and then they decided, yes, let's put this battery in, let's implant this, I'm really happy. And then 2 years later, now they've had this device, 93 people are still very happy and said that this is significant improvement. So I think that says something. And then 2 years after implant, so we said over 90% of people were still happy. So 94% said they are still satisfied. And then 93% of people are still happy with every result that they've got. So here's another patient here, and these are, of course, real patients. She says it's just fantastic to have a normal life and kind of be back to normal. And she said the procedure was easier than what she had thought. And I think that's really true. I think a lot of people think that this device like sounds scary. Like when I say, because I think a lot of people call it the bladder pacemaker, and it sounds intimidating, but it's actually really, really, really simple. It only takes me about 30 minutes to do it, sometimes up to an hour, but it's usually really easy, do a really small little incision, and it can be done. So this says, are you ready for symptom relief, right? So getting started. So basically to get started with any of this, you have to schedule a consultation, and then, start from the very beginning. And usually I tell patients to kind of have patience as we go through this, because it takes a while, right? I mean, you got to come in, you have to be seen, usually do an exam. We want to get a baseline diary and kind of see where things are going. And then we start with easy stuff like we talked about, like the behavioral modifications, fluid modifications. Maybe they want to go see pelvic floor physical therapy for, a couple of months. And if that doesn't work, maybe we start a medicine, and then another month goes by, and like maybe that didn't work and we start another medicine. And to get to kind of these more advanced therapies like Botox or sacral neuromodulation, like it takes a while. Okay. This is my office number right here. So basically take the next step towards symptom relief.
Thank you. This brings us to the end of our webinar. We appreciate your time so much, Dr. Kaeser. I'm sure I speak for our entire audience when I say everyone learned something useful. I want to thank our viewers as well for joining this session. If you'd like more information or to schedule an appointment, please call Dr. Kaeser's office on the number on that slide. We thank you for joining us, and we hope you enjoy your evening.
Yeah, thank you.